Slip capital femoral epiphysis is a misnomer. Actually, the epiphysis is displaced. Um, Actually, the metaphysis is displaced anteriorly, while the head lies in the acetabular cavity and goes posteriorly. The slip capital femoral epiphysis is commonly at the age of 8 to 12. It is more common in males. It is more common in obese children. It is more common in kids who have endocrine abnormalities. On X-ray, the most clinical definitive findings is a Tretwin sign when the clean line is produced on the lateral margin of the femoral neck. It crosses the femoral it does not crosses the femoral head itself. This means that the Tretwin sign is positive. The patient would come up with a hip pain or either a knee pain. Increased suspicion is important. If I see this patient in A&E, I will do some investigations. That is a history, examination, laboratory tests, and radiological assessment. Regarding the history, I would need to check the duration, the complaints, any previous episodes of such complaints, what activities of daily living are hampered of it. Regarding the examination, I would check the patient. The foot progression angle would be in external rotation. Regarding the examination, I will see for obligate external rotation while the hip is flexed. This is called Renham sign. I will check for the tenderness at the hip region itself and confirm whether the patient is walking with a stick or without a stick. If the child is able to ambulate as per, it is classified as per Cotton-Lowther classification. The Lowther classification states stable and unstable hip. A stable hip is the one in which the child can ambulate with or without crutch. An unstable hip is the one which the child cannot ambulate. Anyhow, the unstable hip, the risk of AVN is 47%. Further investigations would consist of radiology, that is X-ray. I would prefer to do an AP view of X-ray and a cross-table view. I can understand that frog-leg lateral view is better, but it is dangerous in states of acute slip when it can displace it further. Regarding the classification, it's a Southwick classification. A Southwick classification is done by doing a frog-leg lateral view and checking the angle. If the difference between the two hips is less than 33%, then it is a type 1. Type 2 is 33 to 50%, and more than 50% is type 3. Then there is a classification which is of chronicity, which is being the acute and chronic. Acute is less than 3 weeks, and chronic is more than 3 weeks. Or acute and chronic, in which the patient does have these symptoms, but there is an episode of acute injury which causes the increased symptoms that patient is received in A&E. The X-ray findings are: number 1 is epiphyseal height is reduced. Number 2, the joint space is increased between the epiphysis and acetabulum. Number 3 is the Tretwin sign, which I discussed earlier. Number 4 is Kappener sign, when the metaphysis is outside the acetabular margin. All of the metaphysis outside the acetabular margin. And third is metaphyseal blanch of steel, when there is ossification changes which is evident at the AP view at the level distal to physis. Regarding the controversy regarding slip capital fibrosis are when to fix it, how to fix it, do we fix the opposite side? Regarding all these three, there is a paper from Southampton which states that the acute fixation, early fixation within 24 hours is better in mild to moderate type of slip capital femoral epiphysis. A single screw is passed, which can be a 6.5 mm screw, which is crossing at least 5 threads through to the epiphysis. The 5 threads is important because we need to achieve a fusion. Regarding the operative intervention, I do not need to reduce this fracture itself. I plan to put the patient on a slide traction table, or if the reduction is needed, I will try to flex the hip and avoid external rotation, and that would give me an optimal position. After placing the patient on traction table, I will take an image which is AP and lateral. In the AP image, I will take the K-wire and draw a mark. Then I will do a lateral image and do another mark. And superiorly, the triangle which is produced is my mark of stab incision. Anyhow, mostly the entry point is anterior to the neck, as the epiphysis is displaced posteriorly. The incision, the screws should be parallel to the epiphysis, so it crosses, and you should have at least 5 threads into it. I have seen surgeons who are doing it without traction so that they can do a frog-leg lateral view and make sure that the screw is not crossing into the joint. Anyhow, if the screw is crossing into the joint, I can do it by, using cannulated screws, I can put dye into the hole in the cannulated screw and see if it's traversing into the hip joint. If it is, I'm sure that the screw is inside the hip joint. I need to change the trajectory of it. Recently, 5 to 7 years back, a study from Elder has shown that moderate to severe slips are better treated with operative intervention. In a severe slip, they have indicated that the risk of non-union is slightly increased, but there is optimal fixation of the fracture. So in moderate to severe slips, we have to remember this. The reason being that when there is severe slip, it is sometimes nearly impossible to cross and fix the epiphysis. Moreover, I know the controversies of when to fix. What I mean is that whenever we see the study from Southampton has shown that if we fix the fracture within 24 hours, that's feasible. But if the patient is delayed more than 24 hours, the vessels are already kinked, and any reduction maneuver would hamper the blood supply even more. In that situation, we convert this acute phase into a chronic phase by placing the patient in a skin traction and later on do an intervention. Regarding the proximal femoral osteotomies, I would like to have approach, dislocate the hip and do osteotomy, which is a done osteotomy, which is near the deformity at the level of femoral. Then is a Southwick osteotomy, which is at the busy cervical region, and a Eimhauser sort of a osteotomy, which is done in subtrochanteric region.